right, in this video I'm talking about report cards in healthcare, and specifically I'm talking about situations where report cards can backfire. So this is where the government decides to report quality of care, and this could be death rates, it could be hospitalization rates, anything related to the patient quality of care for specific doctors, and how sometimes when you report that, there can be some negative unintended consequences. So, to do this, I'm going to be looking at a study that was from 2003. I'll put a link to this description below. The context of the study was 1992, and there were two states, New York and Pennsylvania, that decided to make public information about doctors' records. Specifically, what is the mortality rate for doctors who do cabbage surgery? And this is heart surgery. Some patients die from the surgery, some patients survive, and they adjusted those death rates, those mortality rates, based on the patient's risk. So that was the situation. They wanted patients to know the doctor you're going to get surgery from, how often do their patients die? That seems like a great thing. It seems sort of universally beneficial to patients for sure and to the healthcare system, but there ended up being some negative consequences. So the data set they used was of Medicare patients in those two states, New York and Pennsylvania, and also a third state, New Jersey, because that state acted as the control state since New Jersey did not have the report cards in 1992. And of course, all economic studies are not all economic studies. Many economic studies are going to use an identification strategy, which is a way of figuring out what's causal and what's just correlation. So an identification strategy is going to make it more likely that the relationships we observe are actually causal rather than just correlational. And they used a differences in differences approach, which basically looks at before and after a policy is implemented. In this case, the policy is publishing the report cards, and they control for trends in states that don't have that policy being implemented. So in this case, the treatment groups are New York and Pennsylvania patients, and the control group is the New Jersey patients. These are all heart patients who might potentially be in the category of patients who could need such surgery. So, what were the results from the study? This is a direct quote from the article. It says, overall, this led to higher costs and a deterioration of outcomes, especially among more ill patients. So that's a horrible negative consequence of this well-intended policy. The question is, how did this happen? And that's what I'm going to try to explain. So here's a slide that shows the three things that they're reporting. Better matching, which is a good thing. That was a positive result from the report cards. But higher spending, so that could potentially be a bad thing if we don't get better outcomes. And in fact, the third thing they found was worse outcomes. So better matching, they found improved matching of patients with hospitals and patients with doctors. So what was going on here was sick patients were more likely to spend the time to figure out which doctors to go to. So the sick patients were driving further distances to get to the better doctors. And you can imagine this situation happening in person, right? You're kind of a risky patient, and the surgery is risky for you because of all your secondary medical conditions. You have other health issues that are going to complicate the surgery and increase your risk of complications. So you know that this is risky, and so you're worried about it, and you're going to spend a lot of time looking for the doctor that's the best match for you as a risky patient, and you may be willing to drive further. If you're a healthy-ish patient and you're less likely to have complications, the conversation about this surgery with your doctor is less doom and gloom. The doctor's not as worried when they tell you you need this surgery. They're kind of like, oh yeah, you're healthy enough, and so you're a very good candidate for the surgery. So you're not worrying and spending a lot of time finding the perfect match of a doctor. Maybe you don't even utilize the report card information. So better matching of patients with doctors. That's a fantastic outcome. and it's the first outcome of this study that they found. The second outcome is higher spending. So what happened here? In the study, the quotes in red are quotes from the article, increased quantity of cabbage surgeries. So why might you get more surgeries happening if you're reporting doctors' death rates? Why? Well, basically, if you're a doctor, for one, you're feeling kind of vulnerable that they're publishing your death rates. That's information that you're a little worried about getting out, because all doctors have death rates. No doctor's perfect, and some patients would never have survived surgery. You just didn't know that before they went in. But you want to look good to the public. So what do you do to look good? You add more patients into the mix who are healthy patients who didn't necessarily really need the surgery, but they're pretty low risk in terms of their probability of dying. So adding more patients like that into the mix increases the denominator without increasing the death rate in the numerator, and that's going to make your death rate go down, your mortality rate go down. So if you want to look good to the public as a doctor, your best strategy is to take on as many healthy patients as possible into the surgery so that your complication rates go down, so that a lower percentage of them die. Okay, so that's how we get more people getting surgery. It's the incentive for doctors to reduce their complication rate might mean increase healthy patients having the surgery, or healthy-ish patients having the surgery. And then the third outcome we had is worse outcomes, and particularly worse outcomes for the sickest patients. So how did this happen? And here's the direct quote from the article, and changed its incidence of cabbage surgery from sicker toward healthier patients. So the worst outcomes happened because the doctors were less likely to do surgery on the sick patients they were doing surgery on before. Anytime you do surgery on a sick patient with lots of secondary conditions, there is a chance that that patient will die. The sicker you are, the higher chance you die, but of course doing the surgery also helps the patients. So sick patients previously, prior to publishing these scores, these death rates, sick patients were getting the surgeries because doctors viewed it as being worth the risk. Even though a higher percentage of these patients will die on the surgery table, having the surgery for the ones that survives is going to prolong their life and improve the quality of their life. So they do this cost benefit, and they decide to do surgery on these sick patients. But now suddenly, if they're penalized for taking sick patients, because that's going to increase their death rate, the doctors are not going to do as many surgeries on sick patients. They'll just say, you're too sick to do surgeries on. So let's look at this slide. This is going to be a visualization of what happened. And here's the situation. We have different qualities of doctors. We have the high-skilled surgeon, and the high-skilled surgeon may be more experienced, may have done more surgeries on patients like these, may just be that have a lot of practice and be a very skilled surgeon. The low-skilled surgeon, maybe they're a younger surgeon that doesn't have as much experience yet and hasn't dealt with as many cases. Either case, there's going to be higher and lower quality surgeons. And then we have these 5 types of patients. So we have patients that are really, truly too sick for surgery, that any doctor that looks at those patients is going to say, based on how many complications you have, the probability that you'll die on the surgery table is not worth the benefit to you in terms of your heart from getting the surgery. So for those patients, no doctor is going to want them to have surgery. And then there's these other 2 patients, the purple and the blue patient, who are healthy enough for drug treatment instead. The doctor knows they don't really need surgery. They can just use some drug combinations and some lifestyle changes, and that's actually a safer approach for those patients. So the actual recommendation for the purple and blue patients is no surgery. They're pretty healthy. But of course, all these patients have heart disease of some sort. They're healthy, conditional on having heart disease. Now, the green patient is a good candidate for surgery, but they're also pretty low risk. So when the doctors do the cost-benefit analysis for the green patients, they say, actually, there's a low enough chance you'll die on the surgery table because you are pretty healthy, but we believe that the benefit to the surgery for you is better. So any doctor is going to look at that green patient and say, yes, you should get the surgery and come have surgery with me because you're going to make my numbers look good since you're not likely to die. And then we have the yellow patient. The yellow patient is a high-risk patient. They may have a lot of secondary conditions like diabetes and asthma and many complicating factors that make them at high risk, maybe obesity, things like that. Maybe they're older and more frail. So they have higher risk, meaning there's a higher chance they will die on the surgery table. But the yellow group are patients that really should be getting the surgery. Like when you do the cost-benefit analysis, the doctor should say, even though you have a higher risk of dying on the surgery table, the benefit to your heart from getting this heart surgery is good enough that it will extend your life, improve your quality of life enough, it's actually worth it for you to go to the surgery table. But of course, nobody wants those yellow patients in their statistics because those patients are going to drive up your complication rate. All right, so what happens before we have doctor report cards and after? Before the report cards, the people who get surgery are the people that should get surgery. They are the low-risk patients for whom the cost-benefit analysis says surgery is worth it, and also the high-risk patients for whom the cost-benefit analysis is worth it. This is the green and the yellow patients in this analysis. Now, after the report cards are published, once doctors realize they're being penalized if a patient dies on the surgery table, we get a switch. This is the group of patients that get the surgery. It's the low-risk patients who should be getting the surgery, the green types, but also some of the low-risk patients who previously were not getting surgery because they could do just fine with drugs. But the doctors know that pulling those blue patients in is going to make your statistics look good, and keeping the yellow patients out is also going to make your statistics look good. So how did this lead to the 2 negative unintended consequences? It led to these because we have more people getting the surgery because there's a lot of people in the blue group. And there's more people in the blue group than in the yellow group, so when you switch from green and yellow to blue and green, you're going to have an expansion in the population that's getting this surgery. So that's leading to higher costs. What about the lower quality? The lower quality happens because those yellow patients were truly benefiting from the surgery. Even though they had a higher complication rate, a higher death rate, they were benefiting. So suddenly the yellow patients are worse off because they're less likely to get the surgery that they really need, since they would make the doctor's statistics look bad. And we have worse health outcomes for the blue patients because the blue patients really shouldn't be having surgery. Some of them are going to die on the surgery table. Some of the complications after the surgery are going to make them less healthy. They should not have been getting surgery, but they're being pulled in to get surgery to make the statistics look good. So both the blue and the yellow groups of patients have worse health after the report cards are published. That's a problem. That's a huge problem, and this is one of the negative unintended consequences of physician report cards. And this is the same slide as before. Just to drive home that point. All right, what are the other issues with report cards? There are some other issues. I'm not going to go into these in detail, but I just want to sort of highlight a few of them very quickly. Who do you reward? Do you reward the doctors for the death rate or the group of practitioners? Because how well a patient does on the surgery table is really a function of their primary care before the surgery, their relationship with the whole medical team, nurses, surgeons, technicians, and everybody in that surgery room. They're kind of working as a team. So report cards sort of place all of the responsibility on one individual, whereas oftentimes the team has a really big impact on how well surgery goes. Another issue with report cards is that oftentimes there's a small sample size. If a doctor only does 10 of these surgeries per year, that's a really small sample size, and you can get random huge upticks in the number of deaths or their death rate because you only have 10 people. So maybe randomly 3 of them died, and that's going to make you look like you're a horrible surgeon. Or maybe you're not that great of a surgeon, but you randomly got patients who didn't die. The small sample size problem with report cards is huge because it's not going to be meaningful unless a doctor does a whole bunch of the same type of surgery. And most doctors are doing many different types of surgery, so their sample size of any one particular type of surgery might be small. And there is a lack of agreement among doctors on what treatments should be for patients, and that makes it really difficult to tell. It means that we don't know, we as researchers don't know which of those patients are the yellow type, which are the green type, which are the blue type. That's hard for us to observe. So if you go to a doctor and you say, wait a second, it looks like you're taking too many healthy patients, they can just say their medical expertise says these are the patients they should take, and look at their wonderful low death rate. Isn't this what's indicated? So it's really hard with data to even have that conversation back and forth between the people generating the data and the doctors about what are best practices. And then, of course, report cards can compete with consumer report cards. So that's just another thing to think about. Now, the last thing I'd like to talk about here is, what about this risk adjustment? Because both Pennsylvania and New York were not just publishing raw death rates. They were adjusting death rates based on the patient's risk status. So you would think if they're adjusting for risk status, you might think that that would take care of this problem. Ideally, the risk adjustment should know, oh, you're a green patient, you're a yellow patient, you're a blue patient, let's just adjust you. And this next portion of the video is me showing you why that is not the case. Okay, so imagine this graph where we have, on the x-axis, we have health status that's observable to the policymaker or to the person who's putting out the report cards. All they know is death rate. They maybe know the list of the patient's illnesses. They know age, gender. They know these very easily measured, reportable things. That's what's in their data set. That's how they come up with the risk adjustment score. That's on the x-axis. Now imagine the y-axis is information about a patient's health that is only observable to the doctor, or that is not observable to the policymaker. So this might be the doctor can tell how lethargic a patient is. The doctor can tell how much energy they have. The doctor can tell their attitude, like how likely they are to take their medications, maybe how much social support they have following the surgery. The doctor can tell just generally what is the whole holistic patient like. And a lot of that information is not easily measurable. So the doctor definitely does know more than the policymaker who's generating the report. Okay, so you might imagine in your head, what would this graph look like? And if you want to stop the video and try to make dots for patients to see what kind of patterns do you think we might observe, go ahead and stop the video and try to do that. But let me show you the way I do it. Okay, I think this is something of a pattern for really healthy patients who are healthy along the observable characteristics. There's less of a spread, there's less variation in the unobservable health, the y-axis. And the y-axis is unobservable to the policymaker, but observable to the doctor. So basically, healthy patients, you look at them, they're all pretty healthy. There's not a lot of variation. For patients who look unhealthy, so let's take a patient who has diabetes, asthma, and heart disease, those 3 things. And let's say they're 70 years old. So we know those 4 things about them that puts them in a particular risk category, and they actually look pretty unhealthy, and you're adjusting for that risk. Well, if you take all patients who have those 3 illnesses who are 70 years old, there's going to be a huge variation in terms of their reaction to their illness and their relationship with their illness. Some of those patients will have researched the illness like crazy, will have read a bunch of medical literature, will have adjusted their lifestyle. Maybe they have a lot of self-control, they have a lot of help from family members in managing the lifestyle changes that are recommended. They're just like go get 'em types of patients. Those patients might still be in the same category, the diabetes, asthma, and heart disease category. But you take someone else who's also 70 and also has the same 3 illnesses, and they're struggling with poverty, they're struggling with homelessness, they're struggling with addiction. They don't have a strong social support system. They don't have the background to be able to read medical literature about their illness, and they don't have the resources in their life to manage their illness well. If you look at the actual probability of dying on the surgery table between those 2 people who look identical to the policymaker or to the person who's generating report cards, there's a huge difference in who will actually die on the surgery table. Doctors will probably look at that patient with high socioeconomic status, high social support, high all that stuff, and they'll say, yes, you're a fantastic candidate for surgery. The other patient might also really need surgery and maybe should get surgery, but the doctor knows when they look at that patient that they are at a much higher risk of dying on the surgery table, just because of all these complications in their life. And the doctor, if the doctor is embarrassed about their score and wants to look good to the public, and if that's one of their main motives, the doctor may look at that low socioeconomic status person who doesn't have the resources to manage their illness well and say, nope, I'm not going to take you anymore. You're going to make my numbers look bad. So what I'm trying to point out here is the fact that there's not going to be equal dispersion of patients across this graph. I think that's a very systematic thing we'll find in the healthcare system, and it means that risk adjustment is never going to perfectly solve this problem I've described in this video. So that's my spiel. This is why sometimes well-intended policies have negative unintended consequences.